Hi, my name is Pradeep Natarajan. I'm the Director of Preventive Cardiology at Mass General Hospital at Boston, Massachusetts. The key takeaways are to identify side effects for major LDL cholesterol lowering strategies and strategies to mitigate those side effect risks, and to identify considerations for pursuing non-statin medicines to lower LDL cholesterol. Important to recognize what are the statin-associated side effects that have been demonstrated in randomized controlled trials. There's a lot that's been written about in the press and also a lot that's on the internet as well. So important to recognize that in a randomized controlled trial, people in the placebo arm and also on the intervention arm do report events. Importantly, the most recognized side effect of statins is muscle complaints or myalgias. In virtually all randomized controlled trials of statins, individuals in the placebo arm as well as the statin arm do report muscle complaints, and the rates are virtually identical. Now, if you look in the population, people report up to 1 in 10 individuals on statins have myalgias. Some of it is probably to some degree recognition that this may be an anticipated side effect, but also lots of people on statins also are at risk for musculoskeletal issues, and there is obviously often overlap. More recently, there have been sophisticated N-of-1 clinical trials taking patients who have clear myalgias who are on statins and then blindly randomizing them to statin versus placebo in a random order to try to see if their symptoms correlate with whether they're on the statin versus placebo. Most of those patients actually do not have a clear correlation between the statin and placebo and whether they have muscle complaints, but a subset do. So it's important to recognize and partner with patients that myalgias that occur when patients are on statins are more often to be due to non-statin etiologies than the statin itself, and does require a fair amount of vetting and retrial as well. Liver function abnormalities are frequently observed in the context of statins. Overt clinical liver hepatotoxicity is exceedingly rare. And so the guidelines have moved away from routine ascertainment of liver function testing because it does not seem to predict clinically significant liver disease. Importantly, another side effect that is described is the risk for diabetes. This side effect was recognized when pooling lots of clinical trial data together to tease out a clinically significant but very modest increased risk for type 2 diabetes. So how do we work with patients and minimize potential statin-associated side effects? As I said, myalgias are frequently reported in patients with statins. It's important that it requires counseling, reviewing the literature, reviewing the expectations, understanding that if myalgias do occur, it's more often related to non-statin mechanisms as opposed to the statin. For many patients, it does require shuffling around the statin regimen, potentially reduced doses, potentially coming off the statin and then trying back again. Checking thyroid function is important because hypothyroidism is an important reversible risk factor for statin-associated myalgias. Hepatotoxicity, we said that clinically significant hepatotoxicity is exceedingly rare. As such, we don't routinely check liver function tests. It may be helpful to have a baseline set of liver function tests for patients who have hyperlipidemia, for whom you're starting a statin. If those are normal at baseline and there aren't additional risk factors, repeating the liver function test after a statin is unlikely to change clinical management. For some patients who have abnormal liver function tests at baseline, who also have hyperlipidemia, may also have fatty liver disease and would also benefit from a statin. So I would be cautious if there are liver function abnormalities after initiating the statin. If it's a small amount of elevation, then that usually is okay and requires some degree of closer monitoring. The Diabetes Association is an important biological relationship. It seems that this extends beyond statins. There is an inverse relationship between LDL cholesterol and diabetes. The complex biology is not well understood in the current literature. Importantly, for patients for whom statins are recommended, the very modest risk for diabetes is pretty small compared to the potentially very large benefits on the cardiovascular disease side. For patients for whom there may not be a substantial benefit from statins who have low cardiovascular disease risk, given the modest risk for type 2 diabetes, it's possible that that may not totally make sense for those patients. So important to talk through patients about anticipated side effects, as well as going through strategies about how these can be minimized. key considerations for non-statin, non-ezetimibe, newer cholesterol-lowering medicines. Bempodoic acid is an oral medicine. It's taken daily. There is a preparation that is in combination with ezetimibe. So for patients who are on ezetimibe without an additional copay, at least as it stands today, they can get just a separate pill that combines ezetimibe with bempodoic acid. There is a very important risk for gout for these patients, about 1 to 2%. The risk appears to be restricted to patients who have had gout before or who have hyperuricemia prior to starting bempodoic acid. So for all patients for whom I'm considering bempodoic acid, if they have not already had gout before, I check uric acid levels. If it's elevated, I usually pursue alternative strategies. There are also PCSK9 monoclonal antibodies. These are subcutaneous, administered at home by patients. These are medicines that are taken every 2 weeks, evolocumab and alirocumab. Evolocumab has a higher dose preparation that is taken every 4 weeks. There is greater prescription burden because in addition to the other medicines that they're on, they'll be taking this medicine as well. There is a modest but significant increased risk of injection site irritation. Beyond that, there hasn't been described substantial risks as it relates to myalgias or hepatotoxicity. There's also PCSK9 siRNA. There's only recent experience in the US as it was just approved by the US only a couple months ago as of this recording. It's been approved in the United Kingdom in 2021, also with limited experience so far. It's subcutaneously administered. It's intended to be administered at a physician's office or some other healthcare facility, but it's only dosed every 6 months, quite similar to many vaccines. It's an additional prescription burden, but it's not something that patients are doing themselves at home. There is a slightly greater risk for injection site irritation. Beyond that, serious adverse consequences have not yet been described in the literature. So in summary, statins and ezetimibe are the first-line therapies for LDL cholesterol lowering. Bempodoic acid, PCSK9 monoclonal antibodies, and PCSK9 siRNA represent additional strategies to further LDL cholesterol lowering. Thank you for watching. I hope you found this educational video helpful.